it.
There we go. And actually, I turned on the live on YouTube, so we'll at least have the YouTube going as well. All right, so let's continue on where we were. I think we left off with Michael, and then Dr. Summers. Did I get yours? Did I get your thoughts? Yeah, on what you're
No,
facing
not
in your
yet.
area. Okay, let's go for that.
Yeah, I mean, obviously for my colleagues, very similar stories, but we've come through COVID. We have a lot of chronic concerns, but I guess the three things that are really somewhat new that we're focusing on is, as noted before, the staffing challenges, the Great Resignation is one, burnout, and not just physician burnout. And it's easy to say, oh well, I'm a CMO, I'm Chief Medical Officer, but this is staff, this is nurses, this is nursing assistants, NPs, PAs, and we have a role in that with burnout and working to help our employees. And then finally, workplace violence. That has really been something that is, maybe I didn't realize it because I was so focused on COVID, but now I realize it. And the amount of threats, be it direct violence versus verbal statements, etc., has increased, especially in our emergency departments. And so we have to be very proactive in dealing with that in multiple ways. And I'm happy to talk more about that. But those are, among all the other things that we deal with, for years, those three things have really stood out as new issues that we're having to solve.
Absolutely. So we're going to definitely be diving more into that. Dr. Stalos, what about from your perspective? What are you seeing?
Yeah, so just like my colleagues, there has been a pain point in the personnel, but in addition to the burnout, there has been issue with retention and encouraging people to enter the field of the laboratory sciences. So that has been a big topic just recently because there is legislation that is being proposed that would broaden the qualifications needed to work in the laboratory, and it's meeting some pushback from the people who are in the laboratory space right now, because although the pandemic emphasized the lack of qualified personnel to work in the laboratory, and that was part of the issue of getting laboratory tests online, we don't feel that, or I'm just going to talk myself, I can't represent everyone, but it is not, I do not feel that to dilute the requirements to work in the lab is the solution to creating more personnel in the laboratory space. There can be suffering on the other hand if you let people that don't quite have the required experience to work in the lab. There can be a increase in the lab test errors, which was seen in one of the states that started to dilute down the requirements to work in the lab during COVID. And then, wow. And probably left unsaid here is the money part. So the clinical lab space has had a lot of battles this past 2 years, not just COVID, because on top of COVID, we've had the legislation piece that wanted to decrease Medicare reimbursements for pathology lab tests performed. And that started back with PAMA 2014, and it was finalized in 2016. And then that was met by support from a laboratory organization, written down the American Clinical Laboratory Association. They sued the government to appeal the proposed decreases in laboratory reimbursement, and they were later supported by the College of American Pathologists. So we've had a lot of battles on our hands in the laboratory industry, and so those are just a few of the pain points that we've been experiencing.
Well, thank you for that. Thank you for that. So we're all not live on LinkedIn now. I was able to remove it and bring it back. So we're actually all live on LinkedIn. And those who are just now signing in for LinkedIn, let us know what city, state, what country you're from. Feel free to pipe in any questions that you have. Let's get right into our topics because we're all limited on time. Let's talk about addressing the safety and well-being of staff. When it comes to decreasing provider burnout, I know you had some thoughts on that, Dr. Nguyen, and whoever else wanted to add on to that, let's definitely keep the conversation going.
Mm-hmm. You know, when we first started trying to address our high turnover rate, right after the height of COVID, a lot of the feedback we got outside of, reducing hours per se, is being able to connect with others at work and also connect on different topics and areas of healthcare outside of the day-to-day. So we actually sat down and talked about what does that look like and what can we actually operationalize. And some of the programs we put together are around after-hour enrichment sessions, whether that's learning Spanish or learning about a hot topic across the country. We invite speakers to come in. And yes, these are after hours, so usually we run it from 6 to 7 once a month. But what we found is that people really do log in, and maybe because it's from the comfort of their own home, their kids are running around in the back. But they do get a sense of that they're learning something more than their day-to-day. And that program has been running for almost a year and a half, and it's been very favorable for us. Outside of the kind of usual team building on the weekend activities, found the actual professional development and personal development has really spoken to our providers. But I think it's always about asking, what else do you need? Of course, there are initiatives that we've really been focusing on for efficiency of practice, and that's just a constant ongoing piece. But we've done a lot of research on what other organizations are doing around the country, and simple surveys, like the 5 stupid things that are bothering you this last month. And we just put it out there and we get very valuable information. And yeah, there are some things that are really stupid that we do on a day-to-day basis. And it feels good to be able to get rid of it. And so I just wanted to make sure we share the really simple, not all costly activities that we're putting together for the providers.
That's great. And any other thoughts as far as decreasing provider burnout? Any initiatives that you've experienced some positive results from? If not, we can move on to our next topic. We certainly have plenty to talk about. Okay.
There are a number of things that we can do when we go out making rounds. I've heard Erik say before when we were together on a previous talk that going out and just listening and paying attention. But asking the question, what frustrates you, to go along with what Dr. Nguyen was just saying, and actually listening to what frustrates people in the workplace. And then, going back and taking that and, working with it and massaging it as leaders to make sure that we come up with methodologies to help people find meaning in what they're doing again. There's an entire program called, Finding Meaning in Medicine. And, at least that's something that we're doing. We're getting providers, APRNs, PAs, physicians together in a social setting. We provide the food, we provide the guided conversation, but we get them to start thinking about, why did you go back into healthcare? What do you still find meaningful? Can you connect back to that which is here? Why you're doing this, okay? Because there are stressors in every job, and how you deal with it is connecting back to that meaning. And so, doing that. The other thing I would say is that, we as healthcare providers, and certainly our physicians and our advanced practice providers are held accountable for 100% of outcomes as healthcare moves from volume to value in the way we get paid. And yet we only have total control over about 20%. And so getting involved in the 80% of, the community needs, water quality, food, transportation, all the things that I alluded to earlier in my first little snippet of the stressors we have here, so that we can try to alleviate those barriers. You have someone that requires, in the hospital setting, someone that requires going to a facility, but we can't find a facility in the post-acute world to send them to. And so how do you do a safe discharge? Those are all the kinds of things that we also need to be hearing our staff and then working to give them answers, so that they feel like, though they are facing stressors in their work life, their workplace, that someone is listening and someone is actually making an attempt to help them with that.
Makes sense. Yeah, absolutely. And then I know, Dr. Summers, you wanted to touch on, as we're speaking about the well-being of staff, addressing workplace violence. What have you seen from your end in terms of the problem, as well as proposed solutions or initiatives to help decrease it?
Yeah, so I touched a little bit on the problem and the data and how, you know, we have been measuring this for 10 years, and how we measure it is we've created a process where our staff can send in what we call RL6 reports, or concerns to administration with regards to violence, and that has increased. I'm just looking at it right now, by over the last 10 years, 250% of these
Wow.
violence reports, and each year it keeps going higher and higher. And you know, 5 years ago, sure, there were some cases, but now it's on the forefront. And so what I have learned over these last couple of years are three things. One, you have to create an environment where your staff report and feel comfortable reporting. If you don't have that, then you're way behind in the game, because if people don't feel comfortable reporting, or it's not easy for them to report, then you don't know your problem. But that being said, and I feel like we have created a process where now, you know, based on the 500 cases this year so far of workplace violence, that we've gotten that reporting structure. So that's good. But then that becomes incumbent on your leaders to do two things. One is action. You know, people are not, you know, and these reports will break your heart. I mean, you know, a nurse getting slapped across the face, or a nursing assistant getting stabbed with a pin in the chest, and that's just off the top of my head. Those are emotional, and people took the time to write that out. They want to know, you know, you as leaders, what are you doing? You know, are we implementing metal detectors? Are we, you know, what is our security? What is the opportunity for, you know, we now have badge alerts. So there's that piece. But the third piece, which I think is just as important as action, is, and Dr. Torres touched on this, is listening. And it's not listening on a WebEx. It's going to the floor, and it's meeting with not just the person that got slapped across the face, but that floor, what they're feeling. And I can tell you from doing this over and over again, it has an impact. First off, there's a little bit of surprise. Oh, a leader even knows about this? You know, oh, there's somebody coming. And so we're changing that culture. Every case, we want to be there, and we want to hear firsthand, not only the event, but how it felt. And that has a tremendous impact. It's, for me personally, it drives me that what can I do? What actions can I take so that this doesn't happen again? You got to have all three if you're going to make an impact on workplace violence. And this is probably one of these problems that's now a chronic issue that we'll be dealing with for years.
Oh wow, that's impactful. I'm curious, when you say the badge alerts, how does that work with the badge alerts? If something goes off on their badge, if something's
yeah, I can show you. So we have a little badge, and you have a little red button. You press that button, security is alerted. They come right away. And so, you know, we can't have security in every hospital room or on every floor, but we have them in the area. And when somebody hits that badge, we want them there as soon as possible, because for those who've been involved in these cases, they can get out of control very quickly, and you want the right support. So that's just one piece of a big puzzle, a big problem with workplace violence. But we want to protect our staff. We want to support them. You know, you can imagine that impacts workplace violence, impacts burnout. It impacts people leaving your organization. So you have to address it.
Absolutely. And I appreciate that. Now, also, as far as patient outcomes, we were going to talk about that too. And you touched on it when you said, I think you said only 20% of the I guess, how'd you put it? The doctors or providers only have about 20% to do with it. The other 80% are other external factors, but they're getting 100% of the blame on that, or accountability, if you will. where do you think it should be focused? How do you think it should be measured out?
Rollis, who are you asking? Are you asking me or are
So
you
I was
asking?
asking, I was asking Dr. Torres. I'm sorry. I was going back to his point earlier about the outcomes.
So getting involved in the
Uh-oh.
the things in the community that are the things that we don't have direct control about, the things we control: access to our office, the quality of the evaluation done by the practitioner, the cost of the medication, so that we can be sure that the patient can afford it. We're not giving them the latest and greatest $1,000 a month drug, et cetera. There are things that we can do that we have direct control over. And then there are some things that we have influence. Rollis, you really need to stop smoking 2 packs a day. Rollis, you really need to, cut down on your drinking, et cetera, et cetera. Okay. Where we have some influence, but you leave my office and you continue to smoke or drink, it doesn't matter. But and then there are things that we have zero influence over. And I think about, the places that I've lived. At one point in time, I did my residency in upstate New York, Western New York, and I was right near Love Canal. I could not control the fact that the water in the area where I lived was contaminated with chemicals from, that manufacturing plant from years before. So how do healthcare organizations get involved in illiteracy, education, safety of water and food, et cetera, et cetera? I think those are all things that we need to be thinking about getting involved in. We also simultaneously need to be talking about the safety of our employees. Erik, I want to know about your red button on your badge idea, because I'd love to be able to copy that here. We are teaching all of our frontline staff how to de-escalate, how to identify when a family member, patient, visitor is escalating, and how to utilize the tools in de-escalation. So we are as involved in that as what I'm hearing Erik say is happening with his organization. And so it needs to be a combination. And bottom line is what Erik was talking about, is that our employees and our coworkers having psychological safety. It needs to be safe to speak up.
Right.
And if we don't create that environment, then we're missing the boat, frankly.
Makes sense. Before I move on to the next topic, I'm curious, Dr. Li, because this is like kind of getting into your area here, is this whole idea of de-escalation. What are your thoughts of what you would recommend that should look like in terms of maybe, I don't know, programs, training, or I just love to get your thoughts on it, because you're so involved with that part of things.
Yeah, we actually have comprehensive training for our staff members about workplace violence. We do have structured training. So depending on your work setting, there is whole day trainings where you sort of have more sort of practical skills that are part of the experience, where you're actively involved in case scenarios. And that was actually one of the challenges with COVID, that we had to sort of adjust our live trainings. And then you also have sort of tools that are involved. There's a number of companies that are out there where they have specific structured approaches to how you do de-escalation and do engagement with clients that might sort of become more activated in healthcare settings. The tool that we use and the structure, the product, we use is called Handle with Care. That's sort of one where, depending on your job, you might have less or more involvement and intensity of the training. And so there's a handful of companies out there that help manage this and sort of work through it. I know that in a lot of acute care settings, it's been an area of focus especially as I think, there's been some trends in behaviors of individuals coming to the hospital as a result of some of the changes resulting from COVID, with job loss, with difficulties with housing, and also just some trends in increases in substance use. And, these de-escalation techniques, getting back to basics on having the staff know when to apply it, how to consistently apply it every day, is really important. And so I do think that having whole organizational strategies, where I came from previously to the Harris Center, we did a lot of committee structures around, workplace violence and how do we address it, tracking outcomes, near misses, and, related safety and quality aspects about violence in the workplace. In my current organization, we adopted a event reporting software called RL Safe Care, where we are able to track different instances of events that occur in our different areas. We're also doing a lot more work around just care culture, around reporting, so that folks aren't feeling fearful about sort of negative interactions or bad patient experiences that might have occurred as a result of, what's going on, and sort of fear of punishment. And so there's a lot that we're doing in different areas to really support our staff and really get at some of the burnout and also the risks that might take place in a much more activated work setting.
Appreciate that. No, that's very helpful. Moving into our next topic here, we're going to get into balancing healthcare and healthcare staff, rather, as well as financial concerns. And, I know, Dr. Nguyen, you had some thoughts on that. And if anyone want to add on that, you're certainly welcome to do that. We're also bringing up the comments as some of you are talking. So if you see a comment that you would like to incorporate into your answer and address, feel free and do that as we go throughout the discussion. But on limited time, I may not be able to read all the comments. So Dr. Nguyen, what are your thoughts about how can we take care of staff and make sure we're financially sustainable? I know those are kind of two balancing things to kind of balance. What are some things that you guys have been facing and ways you've started to try and address some of those issues?
One of the consequences of being short-staffed and trying to adapt to a lot of the change is scope creep, and existing staff start to be assigned and asked to do things that they weren't originally either hired for or trained for appropriately. And we all know how heavy that can weigh on anyone when you're being asked to do things that you don't really feel competent to do so. And so one of the things that we've been really looking at, and it just takes a lot of effort and time, is to go back out to the clinics that have been existing for years. So not that we're trying to design anything new, but it's really just going back out there to see what happened. What kind of scope creep are we talking about? What is the nurse now doing that we never intended for her to do, or an MA, or any role really, and start to delineate and almost redo the blueprint for them, which seems sort of silly, right? If a MA or a nurse has been there for years, but we have found that they really welcoming the opportunity to say and raise their hand, just like what Dr. Lee is saying is around the just culture of, I'm being asked to do this, and it's now been an expectation for the last year, but I actually really don't feel comfortable doing it. And kind of listing out those units of work separately, and then coming back to leadership to say, who's going to hold this now? Because we can't just expect our staff to stay with us doing more than what they've been asked originally, and be surprised when the turnover rate for our MAs are so high. And even though it may be that an MA is leaving our organization and going across the street, it may be that the load of work is the same, but it's the desire to have a change of environment, or to feel like finding another organization that might be more supportive or might be listening more. And so It really aligns with what I said earlier for providers too. It's going out there and seeing what's happened now that we're settled into this different chapter after COVID, and then even if we don't have a place for those units of work, just sharing with them and telling them that we are working towards removing that off their plate has really helped us retain some of our staff. So, it's a delicate balance. It's hard. It's an inevitable consequence of losing staff is someone's got to do the work. But I think we've got to be intentional about our communication and messaging to them.
That says a lot, because what you're telling me in some cases, the problem hasn't been fixed yet, but you're just letting them know, look, we're trying to fix the problem. We're trying to address it, and let them communicating with them seems to be having a very positive effect. Would you agree with that?
Yes, I do. I mean, it's a lot, to do with change management and keeping the communication lines open.
Yeah, makes sense. Okay, very good. And in terms of change management, I don't know if anyone had thoughts on that whole idea of change management. Is that something that is it a process that is assigned to a specific person or persons in the organization? Is it something that's kind of embedded in the culture? What's been kind of what you've seen in your organizations in terms of, or as you've observed as far as change management is concerned? I know it's not easy.
Well, I'm curious what the rest of the panelists say, but I would say that's been a topic of conversation for us is how do we structure it so that it's the most effective and impactful? And currently right now, the way we're doing it is it's dependent on the project. And we're having the leads of those projects lead it. But I'm certainly curious to hear if there are other ways to do it more effectively.
So here's what we'll do. We'll allow each person to kind of incorporate into their comments, because we're going to move into ways to address measures that we've taken to address and enhance care delivery. I know, Dr. Li, you had quite a bit on that. And then as we kind of go through a kind of a round robin, if you will, as to whatever's been happening at each of your facilities to help enhance care delivery involving your staff, we'd love to hear that. So what's top of mind for you right now, Dr. Li, in terms of some of the enhancements that you mentioned?
Yeah, I think that for our staff, there's been a lot of different approaches to helping with engagement, helping with workplace safety, as well as helping with getting them the tools that they need to feel successful. And so toward that, for example, for our medical staff, we've been able to incorporate a lot of different key topics into our CME series. And so for our staff, that's been a very valuable series where as a planning committee, we have medical leaders from across our system be involved to provide suggestions and talk about topics like gun violence and prevention and legal aspects of that for places like Texas. And then also, updates from new changes in the legislature related to open carry. And we've had topics related to substance use disorders and how do we manage care delivery very specifically to different populations given the increasing trends of overdoses. I mean, we had a higher increase in overdose trends compared to suicide trends, right? You just sort of see it shooting up during and beyond, throughout the COVID pandemic. And so that's been an area that the staff has had a lot of interest in. So we've sort of incorporated it through educational events. We've also had a number of different engagement and outreach events. So for example, this month, September is Suicide Prevention and Awareness Month. So our system-wide Zero Suicide Implementation Team, which is really a evidence-based framework to do suicide prevention. We've had numerous different types of events, including luncheons, so that folks can meet each other and connect more intentionally. We've had, fun events where folks can wear jeans to work on Fridays if they wear teal and purple to raise awareness to Suicide Awareness and Prevention Month. We've had, thought exchange Thursdays, which are lunch hours during the work week, where folks can just share what's on their mind, and people talk about very poignant experiences with working in a setting where they feel stretched, and then they've also had lived experience with suicide. And it's just like deepening that conversation and working toward meaning finding, as Dr. Torres was mentioning. And so we've done a lot of different aspects, both through enhance the experience of staff, as well as sort of provide educational and development materials so that they can really engage in an easy way. Like, I don't want to pull them their day to day, because they already have a lot going on. And so it's routine things, and sort of really making sure that those aspects of routine processes and meetings are really valuable to them. And so you're sort of losing some of the less valuable pieces and sort of taking away things that really aren't as important, and sort of focusing on the things that people are prioritized and interested in.
Yeah, that makes sense. So what I'm hearing is you were explaining it. In some cases, you pointed to committees. In other instances, you pointed to a team. If you don't mind, because this kind of, to me, it kind of touches on this whole change management thing as you're trying to make changes or improvements. Was there a thought process behind whether you're going to pick a committee or a team, or is that essentially the same thing in terms of how you set up these new initiatives?
So for our new initiatives, when I think about committee structures and teams, I think of them as really being parts of similar, aspects of change management. Like, the way that I think about change management is really based in the Cotter framework, with the different steps of change and transformation that's used in business context that we've applied to healthcare settings. So you really want to set the vision, you want to create the team and the driving force behind it, but then you have to also have steps to accelerate that and engage more people over time. And so where are the forums? How can you leave a group of people to then all sort of go in the same direction, right? You're probably going to have your steering committee where it's sort of a small leadership group. You're going to want to have, more people engaged. There's going to be people that are really engaged, but they might not be able to do decision making, and you want to include them. So they might be part of a larger team, but they're sort of really ambassadors in their areas to really support the work. And then there's the formal, more structured committee structures where you have folks with a charter, with a task, with a driving force, and sometimes more time that are going to sort of really drive the work to propel it to success. And so I think it's just are they exactly the same? It might, when you think about a Venn diagram, it might be partially overlapping because some of the team members might be part of the committees, but I also think of needing different teams for different things, and different sizes. And so you have to be intentional as a leader to be strategic about how you form teams and form structures, because if you say, go to the same old structure and go to the same old committee, and there's not more work being done and it's not really useful work, then it's sort of leading potentially more toward that burnout, because folks aren't doing things in an efficient, value driven and meaningful way. And so you have to be really careful about how much structure you do, how much centralization, decentralization do you do, and what are the goals here? Where do we want to go this year? And so hopefully that sort of helps get a picture of what you were asking about, Rollis, over there.
Yeah, absolutely. And hopefully that helps for you, Dr. Nguyen. I don't know if that's similar to what y'all do, if you do something a little bit different in terms of change management. I'm curious to know too, as far as what are some supporting structures that you've identified in each of your organizations that are going to be helpful in terms of either helping them to be more efficient in providing patient care, or to make better decisions providing patient care. Any thought? I know, Dr. Stalos, you've been quiet for a while, so feel free and let us, if you want to pipe in on any of these subjects here. But I think any of those things that if we could spend the last several minutes kind of focusing on those areas, that would be helpful. And by the way, Dr. Nguyen, Leon Fresh says hello. It's good to see you on here. Go ahead, Dr. Stalos.
Yeah, I'll just say, since we kind of started off talking about personnel and how that is affecting a wide variety of parts of healthcare is that there needs to be an effort to retain laboratory staff. And while we're also trying to create more staff through training programs, that can include laboratories in hospitals, but also perhaps more novel places that may have not been considered before. So, for instance, independent reference labs, or there are universities that did not used to create laboratory personnel before, but are reaching out to develop training curriculums. So that's just one area that I wanted to mention in the change management, staying open to retention and to bringing more staff, because as we all know, losing staff is hurtful to the organization from a functional point of view, but also financially, because it took time to bring that person in, train them, and the loss of an employee is a loss of 4 to 5 times their salary. So it just makes good financial sense as well. So
okay, very good. Appreciate
right
that.
Now.
That's awesome. I appreciate that. Okay, and then enhancements. Any enhancements you can think of that are top of mind for you, Dr. Summers, that you think back over the past several months? And by the way, I also want to ask if any of you want to comment on this point too. Is when you have the top leaders in the government and are saying that basically COVID's over, I want to hear from your standpoint where you're seeing on the ground. Do you feel like that's the case? Do you feel like we're pretty much on the end of this? And do you see the effects also decreasing? So any of those, I'll start with you, Dr. Summers. If you want to comment on any of those things.
Yeah, I'll comment on a few. One, COVID is not completely gone away. I mean, we're running around 30, 40 inpatient cases through our regional hospitals daily for months. I think it's going to be a chronic issue. There may be peaks where things get worse, but I don't mean to be a pessimist, but it's hard for me to see zero. So it's something, at least for physicians, in the hospital, we're going to be involved with that for a while. As far as things that, techniques and things we use in terms of, I'll focus on change management. I mean, certainly we have a performance improvement group that helps us with big projects, but one of the positives of COVID was that it showed me that we can make change extremely fast when we need to. Emergent, urgent issues, we were moving them like that with COVID. And so that was helpful to see rapid change. That was good change, and how we did that. Things have settled down a little bit, but there are certain basic things that I try to do with any change in the organization that we need to make. One is, I think of committee, I think of a big group. When I think of team, I think smaller. And so you have to, all these issues are important, but when you have 20 people in the room, things seem to be less efficient. So I try to keep a small group. And the big one is, I want the people on the front lines. I can tell you that nurses have done great things for me in my career. Not just, as a medical student, as a resident, even now in administration. When there's an issue, let's say pressure ulcers, improving pressure ulcers, the top floor certainly has knowledge, but the front line will tell you, the nurses, the nursing assistants, they'll tell you exactly the core of the issue and the thing you need to focus on. So just because somebody may have only been in your organization for a short amount of time doesn't mean that they don't have a voice and value to solving a problem. I try to put timelines, because if you don't set a goal, you can be meeting for years, monthly, on the same issue, and you're not gaining traction. You've got to push. You can't be in 1 week, we've got to solve pressure ulcers, but you've got to have some goal to shoot for, to push people to solve it. I mean, we could talk forever on change management, but those are just some basic things. Having virtuous intent, making the right, why are we doing this? We're doing this hopefully to help patients. That's hopefully why we're in this business. And so yeah, those are just some things I think of when I'm talking about change.
Yeah, I'd piggyback on that, Rollis. I think that we as chief whatever, chief operations officer, chief executive, chief medical, chief nursing, the senior leaders need to walk around, and we need, when we make our rounds, we need to make sure that, you know, not only are we asking the types of questions we talked about earlier, but we're encouraging people to speak up when they see something. And I also believe strongly we need to create an infrastructure that provides safety. You know, when you look at the science of safety, there are three basic types of errors, right? There's the simple error. I swear to you, I didn't see the speed limit sign change. I didn't know that the speed limit went from 55 to 45, and that's why I was doing 55. That's simple error. There's at-risk behavior. I was trained to do it a certain way, and then I was taught a shortcut, and I was told nobody ever gets hurt. So I did the shortcut, and lo and behold, somebody got hurt. And you know, those two out of three, so 2/3 of the type of mistakes that we make are truly not with an intent to harm. The third one, willful and wanton disregard, is the only thing that should go to discipline. So the others, at least in my health system, we've expanded peer review from not only the medical staff, but it includes all clinical personnel now. So HR cannot cause an adverse action to be taking place on a clinical employee, nurse, technician, whatever, who makes a error in judgment of the first two types. It's only if it's willful and wanton disregard that we then go directly to, you know, some type of discipline. And so, you know, we can create that kind of infrastructure as leaders. Okay. And we can open up the door to the conversation with the people that we interact with every day, that it's okay to speak up. Okay. I will tell you that in my military leadership career, you know, I'm the officer with the highest rank. I'm the commander of the facility, and I'm learning something from someone who wears one stripe on their sleeve. Okay. And until we have that curiosity, if as leaders we're not curious, if we don't instill an attitude of curiosity, if we don't ask questions like, I fail to understand, help me unpack that. And we tell everyone in our organization, it's okay to speak up and say, I don't get it, help me unpack that. Okay, then we're not creating an environment where people will actually begin to feel that psychological safety.
Oh, that's powerful. Dr. Summers, go ahead.
Yeah. Just piggyback real quick, and then I'll stop. Just piggybacking off of that, that's great words from Dr. Torres, but approachability is the other facet of that. If you go to the floors and they're like, Dr. Summers is here, and they're doing all this stuff, you're doing something wrong. You go to the floors, they should be happy to see, oh, hey, Erik, let me tell you what's going on. You can't move forward if people aren't willing to tell you things and you're not approachable. So everything Dr. Torres said is exactly correct, but you got to be approachable too.
That's true.
So,
go ahead, Dr.
So I wanted to speak a little bit to some points that Erik had made, and you had started off this part of the conversation, Rollis, with you know, what if COVID is gone and what that means. And just like Erik, I think when the statement is said that COVID is gone, it's more of a geopolitical statement, not a medical statement. And that's fine if other powers want to state whether it's a emergency or emergent, you know, disease or not. That's one thing. But if anyone looks at the CDC number of cases in a day, it's still 50, 60,000. It's still there. We're still testing for it in the laboratory. So as long as the mistake is not made that COVID is gone, it doesn't mean the disease is gone. Perhaps the state of emergency is not being felt. That's fine. And one thing, another thing Erik had said is, you know, COVID was, you know, it is a situation that caused a lot of havoc, but at the same time is an opportunity, a window to see what we can do better. And, you know, COVID, if we learn from COVID, can become a playbook for things that can be in our near future, and not to get alarmed by monkeypox, but perhaps COVID happening beforehand is paving the way for ways we can handle other emergent diseases better. If you go to my LinkedIn, I had talked about how come the Laboratory Resources of the United States, which is the Laboratory Resource Network, the LRN, it's a pre-designated set of laboratories that include environmental laboratories, biological warfare laboratories, just they're pre-designated because they need to be able to catch, anthrax being released or other terrorist type of activities that could be affecting us. And why weren't we involving them more to kind of have a game plan in place to utilize them rather than have this free-for-all where labs were popping up and other labs that perhaps should have stayed focused on the test menu they have, we're now trying to launch into the laboratory developed tests of COVID, and laboratory developed tests are not easy to get up and running, much less to a novel organism. Okay. So that I think that those were very good points that I kind of wanted to expand on. Appreciate
that. Thank you. And we're coming towards the end. I cannot believe how quickly this hour has gone by. And I know we've talked a lot about change management. Now we're coming back to you, Dr. Nguyen, because you're one of the ones who suggested that particular topic. Anything that you heard that stuck out to you, or anything you want to share as a final thought, like a quick 30 seconds to our audience?
I would just say that I think we're all in agreement that change management is really hard. And I think we would also agree that's why a lot of places don't put a lot of effort and intention around it, because it takes up a lot of work. But we know that it's necessary, especially in our environment right now. And I'm just happy to be with other leaders who feel the same way. I can tell that you all believe that it is necessary. And so, I'm happy to have learned, some tips from you all, and I look forward to being able to share more.
Absolutely. No, looking forward to having you back. And then I know, Dr. Li, just to give you an opportunity to wrap, because you've heard quite a few comments here, and you can also wrap up really quickly as well.
Yeah, just I think that, keep calm and carry on, right? Like, I think that there's a lot that we've needed to navigate over the last many years. And I think that as we're sort of entering into winter, wherever you are, and, into the fall, I think it's just good to, keep our heads up high and sort of work through it. I know that even though it feels really exhausting, there's a lot of good that we're doing as healthcare leaders, and good impacts that we're making with communities and individuals, even though it feels like day to day, there's a lot going on. And so I think just, work through, some of it and sort of be consistent and work toward good change, right?
Absolutely. Well, listen, I want to thank all of you for being on today. It's been a great pleasure. Thank you for taking time out of your busy schedules today. I look forward to having all of you back, and we're going to have some clips for this out of this for sure. They'll also be replaying to the rest of our healthcare executive staff as well. So thank you to everyone. Have a great rest of the day. Thank y'all.
Thank you much.
Thank you, Rollis.
Appreciate it. Bye-bye.
Bye-bye. Well, there you have it, guys. Thank you all. Also, just